Thank you. Uh, Great presentations by Ms. Holloway and Dr. Ancker, and I assume we'll probably generate some questions and comments. So let's start over here with Bob.
Rob Logan, National Library of Medicine. These presentations for me are very, very close to home. I taught science writing at the University of Missouri School of Journalism for 20 years. And also I do research in public understanding of science and health. Full disclosure, I've worked with Jessica. I thank both speakers for representing all those disciplines so nicely. And I really appreciate what you both did. Let me reinforce 2 points, which I think may have gotten lost in the aggregate amount of stuff that they communicated to you or discussed. First, there is research, serious research, in the public understanding of health information and the public understanding of science, and also about the news coverage of science and health. There are a number of journals, okay, that are outside the Journal of Health Communication. Unfortunately, they're good, for example, Science Communication and Journals of Mass Communication Quarterly, and those are not new. Many of those journals have been there for 50 years in some cases. And public understanding. Public science, yes. And I think, now again, I know what a couple of people in the room are thinking, how come all those are not in PubMed? And the reason is, I can say that, explain that to you very simply, is that health communication journals are in scope for us because everything in there is about health and medicine. But we have a lot of trouble with social science journals where everything is not about those things. It's very difficult to pick and choose for reasons I won't get into. So the result is that a lot of that literature is something you can access very easily, but some of that literature is not. It's not in PubMed. And that has always been something that has, let's put it this way, when I joined NLM from the Missouri School of Journalism, I joined under one condition, that health communication and a couple of other journals would be put in PubMed, and that it would be part of the reason why I went there in the first place. It's true they already had plans to do so, but nevertheless, my hope is that we can extend it to articles that are relevant in some of these other journals, so that you have access to some of this material and you can see the vitality that's going on those fields. Second, the other thing, and this is something that Professor Holloway mentioned that I'm going to reinforce, there is serious ongoing criticism of health news reporting that evaluates how journalists communicate research data to readers. Okay, the first is in healthnewsreview.org, which she mentioned. Okay, which if you had never seen that website, I guarantee you'll be very surprised, and many of you will be impressed at the level of detail that goes into criticizing what is published in major news organizations on a day-to-day basis. Okay, and that's also not new. It's been going on for many years. I think you'll discover there is a criterion that is used to evaluate stories, and they get very specific about what they have done well and what in many cases they have not. The other thing, again, Marguerite mentioned, but I want to reinforce, is the role of the Association of Healthcare Journalists in essentially professional development of people in this field. That was something that has really been elevated very significantly over the last 10 or 15 years. If you've never seen healthjournalism.org, which is the Association of Healthcare Journalists website, I encourage you to take a look. I think you'll discover very quickly that these are people who are very serious, given the limitations of time and all the things that she discussed, about how we do a better job of elevating what we do. I really appreciate the professionalism that those folks have shown, and I appreciate your presentations.
I should add, I have a bibliography and a list of references that includes many of the journals, so I'll distribute that so that there's a record of them. And also Night Science Journalism Tracker, the Observatory of the Columbia Journalism Review are, exactly as you say, doing an excellent job of assessing coverage in these areas.
It did occur to me, by the way, there's been excellent criticism in Columbia Journalism Review for the last 20 years about how the news media covers health insurance and related issues. Most of that's been done by Trudy Lieberman, someone I know quite well. If you have never seen that coverage in Columbia Journalism Review, once again, I think you'll be very impressed with the degree of detail that she goes into on how to cover these issues better and where there are weaknesses and how to explain things well.
Ema?
First, thank you both very, very much. I want to say that your talk, Marguerite, absolutely confirmed my notion that journalism is probably the best partner that public health could ever have. And we really need to pursue that more. Now, based on your work as well, I would say that I would prefer that every journalist, when in their byline, has a note whether or not they took your course. Because I think that would be extraordinarily important to make that really a part and parcel
I'll
of
issue a
all journalism.
certification. It'll, you know, after their name, it'll be some letters.
Yes,
saying-
exactly, exactly. That would give us an indication. There were two short things that I wanted to highlight. One, we're almost taking mathematical concept terms for granted. So there needs to be an awful lot of attention on words such as normal, range, risk. So you gave a lot of examples about risk, yet never quite addressed the notion that the word risk is rarely, if ever, explained. So I asked a number of my graduate students in schools of public health to give me an example of what they would say to their favorite aunt or uncle who is not in medicine, is not well educated, how they would describe and explain the word risk, and no one could do it. People just fell over their own words. We don't have a good, easy explanation for the word risk. And a former student of mine, Native American from the Crow Reservation, faculty member now, talked about this notion of risk and diabetes amongst the Crow. And she said, when people heard that you're at risk for diabetes, their sense was it's inevitable. That's how they interpreted the word risk when it was given to them. So if it's inevitable, why bother with preventive measures? Why bother with other action? It's inevitable. So I think we have to not just look at numbers and display of numbers, but I think we have to think about the concepts and how we communicate that. And just another thing that might be helpful to everyone in the room, in 1998, Mosenthal and Kirsch, Erwin Kirsch from ETS, published an article in Adolescent and Adult Literacy that provided a tool for measuring documents. And that is extraordinarily useful. I've used it all the time. My doctoral students have used it for all of their assessments. But unfortunately, the only citations that you see in the literature is from us. So I encourage people to look at it. It has the unfortunate name of the PMOSE, P-M-O-S-E / Kirsch, Peter Mosenthal, Erwin Kirsch. Couldn't resist, I guess, giving it their name. The PMOS I Kirsch assessment tool, and you will find it cited in a journal, 1998. I have it on my website with a full explanation of how to use it. And it looks at the structure of visual displays, everything from a list to a chart to a graph, and it tells you how to rate the complexity of it. And it's very much along the lines that you had said.
If I could just reply, that's a great resource to know about. And I think, as I mentioned, I'm in the informatics division. My doctorate is actually in informatics. My master's is in biostatistics. And I think that concept that if there's a mistake being made or a mistaken interpretation, that it is because of some interaction between the individual and the technology, not just at it comes from the human factors tradition in the airline industry. If the airline went down, it wasn't this concept of human error is a bogus concept. It really was something between the human and the interface. And if the wrong light is flashing on the dashboard, then you can't really say that's human error. So this concept that what we need to be measuring is all three parties in that communication: the patient, the doctor or nurse or clinician who's providing the information orally, and then also the whatever documents or websites that are being used is something that I wholeheartedly, and it has been done in like usability testing of websites, but not really from the comprehension standpoint.
Yes, and nicely enough, I would say that there's a factor in health literacy that is growing, that has been trying from the very beginning, and you'll see it reflected in the opening section of the IOM report on health literacy of 2004. The emphasis on the fact that health literacy is not embedded in an individual, but health literacy is the interaction of the interaction of what's going on with the demand side and the skill side. And the demand side involves both the skills of professionals and the demands of a system. So that is a part, not as loud as it should be, but that is always at the foundation of a lot of the health literacy work. And thank you for emphasizing that.
Pat McGarry, AFP. Thank you both. It was, again, very interesting. And I was really particularly interested in the journalistic aspect of reporting out data. And I was wondering if any studies have been done on, people's perceptions of like case studies versus population-based statistics. You were, Marguerite, talking about suicide prevalence. And, your concluding statement was that, well, the general population isn't as big a deal as, that's how I heard it, as it appears. And in fact, it very much so is a huge deal. Suicide is rampant in our country. If you look at the age-adjusted rates for suicide in 2009, it was 11.8 versus 5.5 for homicide age-adjusted rates. It's over twice the rate. So, it's really important to get that construct out there, what those numbers represent, and not that these indicate any level of risk per se, but it's still, it's kind of, we have to be careful how we present that data because that's why I like the MMWR. It's pretty just the facts man kind of thing, and you can draw your own conclusions. So I'm just maybe making an editorial comment that how we present this data is a very crucial construct in understanding numeracy. So thank you.
I don't know the literature well enough to know whether there are studies that look specifically at the issue of the case study versus the population study and its impact on sort of how things are covered or how journalists deal with that. I know that there is always a tension in journalism between, and you see this a lot in healthcare reporting, starting with an anecdote and starting with a case so that you can draw people in. But then often what happens is that's just in the lead, it's just dropped, and then it sort of comes back at the end. It ends up, I think, being kind of counterproductive when it's done that way because it feels almost pro forma or a bit cliched, and I think sometimes it can turn people off. I think when you are able to make a story, an anecdote or a case run through a whole story and then relate it to the larger picture, to the larger population, it has much more effect. And I know a lot of journalists who stay away from just it's not using people, but it can feel a little bit I'm not finding the word, but no. No, not that.
Exploiting.
Exploitative, and definitely feels that it has the potential of turning your readers off rather than drawing them in when it's done that way. That's not really an answer to your question, but that was an observation I thought I'd throw in.
Marguerite, I wanted to make the point that I'm often struck by the fact that medical journals assume that their audience is only practicing physicians. And more today, it seems to me that their audience becomes, just because of the information world that we live in, individual people. And that there isn't an effort made to have a translation done of, this study that has, double-blind, randomized, controlled study with good p-values into something that would be easier for journalists to write about in a way that was understandable to the average person who's walking around getting his or her information from that article. Have you thought about that?
There's a lot of discussion about that because actually some medical journals are very, very good at thinking about audiences that are not just physicians. They're very good at thinking about journalists and how to providing video clips, providing all sorts of press releases, providing all sorts of information to help journalists sort of do things right. And on the one hand, sometimes that can be very helpful and does help us reach the public in a maybe more accurate way. On the other hand, it can be very misleading and manipulative, and journalists have to be very, very careful about over-reliance on any one source that has a set of interests. And the journals have some of them a real set of interests. So I think you just have to, I wouldn't want to generalize about specific journals or go after one or another, but I think that some do really try to communicate to the press and manipulate the press in that way, and the public, and journalists have to use that in ways that are skeptical and also disregard it when they should be disregarding it. There's a real sense that because of the demand to produce all the time, that this problem of relying on press releases from journals, from institutions, it's becoming ever more problematic because people don't have the time to sort of do their own reporting, to find the right sources, and they over-rely on those products, and need to be very, very careful about that.
So I'm wondering if I could ask both of you, oh, Ruth Parker. I'm wondering if I could ask both of you to sort of comment. The field of health literacy is still somewhat nascent. We sort of consider ourselves maybe now in a second generation with, some folks have been writing, thinking, pushing things about it for maybe 20 years and sort of codifying kind of what it means and what it's about. And growing more toward trying to figure out what to do about it now than to really just define the problem itself. But it seems to me, stepping back, sort of thinking about it, that though health communicators and people in the media are natural allies, the field is not very well aligned with people who are in health communication through the media. And I'm wondering what thoughts or suggestions each of you would have about how to forge stronger ties and relationships specifically. And maybe they could even be around numeracy as an issue that deserves heightened attention or shares common interest, and sort of what would an opportunity there be, and how would people who are interested in forming stronger allegiances or bridges between those two areas, what would we go after?
One thought that I had when you raised that is one way in which maybe they're not necessarily natural allies, a couple ways maybe. Journalists tend not to really focus on literacy differences within their readership. You tend to, depending on what publication you write for, you would assume that everybody who's reading it has a certain set of education. So if you're writing for Scientific American, you're assuming you're reading for a highly educated readership. And if you're, writing for a more, even USA Today, more public type of publication, you're assuming they're all sort of the same. So I often find that journalists and public advocates too sometimes don't recognize that there's a significant portion of the population that might need special attention, that the journalists are more interested in getting the information out there, and then that additional level of translation may not really feel within their role. And then I think another issue is that journalists are often take pride in, and are right to take pride in, a certain skepticism about their sources. So even if their sources are the public health establishment, or even if their sources are doctors, as you mentioned, they may have a particular researcher or a particular doctor may have a particular axe to grind that their study is the best thing since sliced bread and you should believe it. Whereas a journalist who's doing their job should recognize that they should stand back from that a little bit and not allow themselves to be seen as a spokesperson for that particular perspective. So I understand where you're coming from. I think that those are two areas where their perspectives are quite different. I would love to encourage more communication back and forth and speaking to each other about how each can improve their communication, but they may not always have the same agenda.
I think that's exactly right. And isn't it great? She's a journalist, she's a statistician, she can present graphical information. What Jessica said. I do think that there is an opportunity to work with associations to raise some of these issues and to discuss them, and then to have it sort of filter back out to the journalists through courses or training, but not in the way that not in the direct way that you were describing. And there was something I was going to say, and I just forgot it.
Can I
It
give
will
you a
come back
very
to me.
specific example and just to drill in on this a little more? Let's say there's enrollment for the ACA starting in October that's part of a new healthcare law for the United States. And there's a tremendous need to understand what you need to do. And there are people very interested in making sure that that content is communicated in a way that it's understandable, that it's actionable, that it's navigable. And it's really hard to get your hands on good content. Let's say there's a group of people, perhaps as part of this roundtable, that are very interested in having that in a way and have assembled some of that content, and they're now interested in helping make that available to the public. We've got journalists that are very interested in getting good information out to the public. How do you marry them?
Again, because there is that very sort of independent spirit, I think you would try to reach out to different publications or media outlets, to editors who are in charge of that beat, or to individual reporters, and again to associations. But I don't think they would necessarily think of it as kind of a collaboration. They would think of it as information that they would like to get, that they would like to assess, and then respond to independently. So I think that would maybe be a strategy.
Let me make a comment. Who here besides me is from Chicago? Okay, so we have a few people who will recognize this story right away. The Transportation Authority, it's now been discovered to have, surprise in Chicago, be very influenced by the politics, people getting people jobs and things like that. Just shocking, I know. Well, the larger organization, which has a responsibility to oversee them, realizes that obviously they weren't overseeing this other board for all this to be now coming out. And what they have done is they have asked the investigative reporters and other reporters in the Chicago area to advise them on what questions they should ask, because they see those people as being more attuned to what do you get at, when should you be skeptical, how do you be skeptical, and realize that they don't have those skills as a board, but in fact the reporters might. Now that's another way that there could be, if you don't want to use the word collaboration, in which in fact we learn, those of us who are in that professional field in healthcare, learn from what it is that reporters do in terms of when you're looking at something, what kind of questions would you ask? What's the kind of skeptical questions you might ask? What is it that you think needs to be explained? Because you've got audiences that you're trying to explain to. And obviously your performance is based on how well you've explained it to your audiences. So it seems to me there's a number of ways that in fact there could be some working together, literally learning from each other. Cindy?
Cindy Brock from the Agency for Healthcare Research and Quality. Jessica, there was one finding that to me epitomizes the struggle that I have in this area. And it was the one where you said that people don't answer comprehension questions better for the graphics that they prefer. And that really resonated with me in terms of a lot of the research in this area, where we have a very mixed bag of studies around simplification. Generally, people prefer simplified materials, but studies are mixed as to whether or not it actually improved comprehension. Similarly, even I remember a FDA risk communication review of the literature said, well, frequencies, percentages, you know, there's a lot of talk about this and the results of the research are kind of mixed. Is there anything that we can really hang our hat on in terms of saying, if we say quantitative information this way, people will have an easier time understanding it?
So what's the secret answer that
Yes,
I've been
the-
keeping
yeah,
from
yeah,
you
the
all
we're talking about the
that
secret
deliberately?
sauce, yeah.
I think I might go back to, again, a concept from informatics is also one that I've been talking about a lot with Ellen Peters today, is something called task technology fit, which is that in human factors in informatics, there's no single technology that solves all problems. It depends exactly what your task is that you're trying to accomplish it. And if the task that you're trying to accomplish with it is not supported by that technology, it will be rejected by users. So stay tuned about whether doctors are really going to stay on board with the electronic health record revolution or not. I think my understanding of the graphics literature in particular, because that's probably the one that I am the most familiar with, but I think this is also true, is that the studies have been confounded in that different people are asking patients to do different tasks. And that's why you end up getting different results. Another thing, one reason why I began my discussion of graphics with these general principles of graphic perception is that what I was seeing was that people were asking something like, are the icons better than a bar chart? When I could see that, for example, the type of bar chart they were using had the part to whole relationship visible, but the type of icons they were using didn't. And so in fact, they didn't recognize that they were comparing apples and oranges. So you get very unstable research results when you do something like that. My sense is that that's the reason for a lot of this. There's another layer of variability, which is that familiarity has something to do with comprehension, and what is familiar to different audiences at different times changes over time. There's a sort of a sociological element to all of this, which means that like the fertility research from the 17th century might not be relevant today. And similarly, we're making inferences on the basis of paper-based studies about how people are going to relate to electronic information, et cetera. I think things do in fact change over time. So I'm not sure if I can really answer the answer that you're looking for.
Yeah, thanks. Steve Rush, United Health Group, and the information coming out today is fascinating. Not only prior to the time that I was at United Health Group, I was the practice and patient safety manager at the American Academy of Neurology. So the idea of risk communications is really, really important from a patient safety and practice standpoint. There are two questions that I have. One is, as we've been talking about graphics, there's this increase in the use of infographics. And I was wondering whether either of you had a perception of how effective that was in terms of getting information out. And my second question was, if I'm working as a practice manager in a clinic, or I'm working at United Health Group and I'm contracting with vendors to create communications, health communications, how do I measure the numeracy burden, if you will, of a communication?
News type infographics, like USA Today infographics, was that your first?
Well, yeah, either news type infographics, but I'm seeing that more and more in some of the health communications that are going out from some of the health plans. And then from, in terms of purchasing insurance. And then sometimes I'm seeing that come out in terms of, go get your mammogram or your prostate exam or whatever.
Yeah, I think I would agree that there's been more emphasis on visual communication. Broadly speaking, this is probably good, because you know, anything was better than what they used to be doing.
Right.
Um, Again, whether individual interventions actually do improve, I think we're going to get the same issue that different things are appropriate for different tasks and different audiences, and it's going to end up being kind of narrow about, like, it's hard to draw this general conclusion. What was your second question? Because I had a really good answer to it.
Is there a way to calculate numeracy burden?
Oh, right. Okay.
Too much information? I can do it visually if you like.
Interpretive dance. I'm really looking forward to that. I don't know of, I would be really interested in trying to work on that, of what is the appropriate, again, what's the appropriate level of complexity in the document, or what's the level of complexity that the individual doctor or clinician should be talking about, as opposed to having all the focus be on measuring the, the skills of the patient. I don't know of one at all. I'd love to start working on it if anyone wants to work on it.
Thank you.
Bernard Dreyer,
Just-
American Academy of
can I come in just for a
Pediatrics.
second?
Oh, I'm sorry. Yeah.
I'm sorry, would you mind terribly if I came in just for a second to
No,
just
not at
mention that several of my doctoral students, now this has not been fully tested, have used the scale, the hierarchy in Andrea Apter's article, and simply put a number next to it. So the one at the lowest got a 1, and the one at the highest we got a level 6, and simply added up the burden in a document. It's almost like you're doing a readability score. So that was just a first foray into that attempt to find a measure. Now, they were not, and we were not at the time, prepared to do a really rigorous study of a good measurement tool, but that was a very nice beginning to be able to document the numeracy burden, for example, of a patient brochure on diabetes.
Within journalism, both in training and at publications, there's a huge emphasis, as I mentioned, on bringing in people who are really good at data visualization to help reporters figure out what part of a story should be written to communicate best, what part is better expressed as a visual, how can we use these different ways of presenting information to sort of bring a much fuller picture. And I don't know about literature, I'm sure there is some on when that is successful or not. But it's definitely a very, very active and I think very evolving and exciting area, because you can do so much if it's not just you writing a story, but you have the photographic elements presented that are most powerful, the data elements presented graphically, and all together you get such a fuller sense of things. And I think that's one of the most exciting things that's happening in journalism at the moment.
Bernard Dreyer. So I have I thought both presentations were really great, and I have a question for each of you, which both of you can answer. But so my first question really is about risk. You focused a lot, very appropriately, on the difficulties in communicating risk. But I think the difficulty in communicating risk reduction is even worse. And actually, most of the time, I find I'm communicating about risk reduction. And, Ellen, in her paper, sort of said you're supposed to use both relative risk reduction and absolute risk reduction. And I believe that, deep in my heart. But how do you communicate, or what do we know about communicating risk reduction in different ways, which often are counterintuitive, although both important?
I don't think I made this explicitly clear, but that whole part to whole thing again is exactly the relative risk.
Right.
That if you're showing only how the risks changed, it does tend to inflate the perception of the risks.
Right.
Whereas if you don't give them any sense of the baseline risk or how that relates to the whole, that tends to inflate the risk. Now, again, we get into are you in the business of persuasion, or are you in the business of informing? And in different contexts, you may have different goals. In some cases, you may, in fact, as a clinician, feel strongly that it would be better for them to quit smoking, and so you would be happy to inflate the apparent risk reduction. Whereas in other situations, for example, when there is no dominant therapy and either therapeutic option is okay, then then that's probably not considered ethical.
Right.
When I do teach the journalists, I mean, one of the take-home, I try to narrow it down to a small number of take-home points, and one of them is never report the relative change without some baseline and
Right.
to compare it against. I don't know if they all do it. We should track that.
Well, a good example for me, which is this dilemma, is immunizations. So because we've eradicated most of the diseases that the immunizations take care of, the present absolute risk reduction is usually quite small, whereas the relative risk reduction, because they're very efficacious, is very high. And so that's a dilemma for me. If I focus on absolute risk reduction, I'm talking about 1% or 2%. It sounds like it's not worth it. And so I think that's an example of a dilemma, and that sort of brings in sort of the concept of historical risk reduction as opposed to what the vaccine has accomplished.
So I think what you're getting at here is that I hope you're not going to be offended when I say this, but I think
No.
you're no longer in the realm of
Nothing
actually.
offends me.
You're not actually interested in informed decision making there. You are interested in persuasion. You have a public health goal, and that you want to promote that. So
Well, I'll push back on that a little, because I mean, my point is the whole story in risk reduction has to do with the effectiveness of the vaccine in producing no measles. But we know if people didn't take the vaccine, there would be measles. So just giving them
But there's
the
like
number,
a herd immunity tipping point. There's a
Yeah,
lot of
right.
issues
Yeah,
there. So
right.
an individual patient's choice not to do it might not, in fact, imperil them.
Correct.
So I'm just going to say that this
You're
might be
right.
one of these areas in which non-quantitative risk communication is actually more effective. And somebody, and I'm hoping someone else can remember, somebody had a very interesting article recently about vaccine risk communications and appeal to altruism, that you're doing this partly out of your sense of responsibility to all those other kids in the school system, some of whom may have impaired immune systems or things like that. So I'm just putting that out there. I wish I could remember whose study this was. Maybe somebody knows. Might have been Gretchen Chapman. That sounds right. She's done a lot of work, and I think yes, that is it. Thank you very much. The advantage of having graduate students in the audience. They're up to date on literature. So again, I just want to say that quantitative risk communication is not our only tool, and it's not always the most appropriate tool.
Hey, that's another example of why these issues have ethical ramifications. That the specific situation that we're talking about and what our goals are need to be considered from an ethical point of view. And the decision about what to do, what the goal should be, and how to achieve that goal may depend on that ethical thinking. Our chairman of a roundtable, George Isham, is now with us, and you had your 10 up, George?
Yeah, sorry I couldn't get here till just a little bit ago, and I didn't hear your presentations, but and I was just going to listen. But then you made that comment about Jessica, about what the purpose would be, whether your purpose is to persuade or not in terms of using relative versus absolute risk. And as I was reading the background materials for the roundtable on the plane here today, on the way here, it struck me, one that's stunning, the amount of challenge we have with respect to people that don't understand numeracy and figures in the population. And then secondly, just reflecting on my own social circle, now that I'm older and into that age group when people are getting cancer and so forth, the number of people I see in social situations who, if they knew what I think I know about cancer, are making decisions for treatment, which, may or may not be, what they would make if they were more fully understood or understood their numbers. And so, is it ethical for a professional, in a situation, whether it's a public health or a clinical professional, in a situation where the vast number of the people that they're dealing with cannot evaluate the information, to use consciously information in a persuasive manner, as opposed to defaulting to the more accurate, absolute risk sort of presentation. And then the third comment I'd make is I think about this during my time on the U.S. task force and the controversy over breast cancer screening. And what was very persuasive to me as we looked at the numbers, went through the evidence, was actually absolute risk numbers in terms of the changes for women in various different screening regimens, every year versus every other year, starting at age 50 or age 40. And absolute differences are very small. And yet the public debate is so inflamed and so different than that figure. And once again, I wonder about the ethics of our policymakers, those in government as well as those in clinical, of how they respond to trying to inform the public and talking to the press around some of these numbers with using statistics which are somewhat misleading. So I don't expect you to respond, since this is more of a rhetorical question. But it really, I think, to echo, Paul, your comment, I think there's a serious ethical issue there, given the facts around numeracy and health literacy, the responsibility of professionals looking at the codes of ethics, and the use of numbers that I think deserves some broader discussion and debate. Not that I know the answer of it, but I just share with you that reflection. If you want to comment, fine. But
I agree about that ethical issue about, really, that gets back is, are we in the business of persuasion, or are we supposed to be trying to be as unbiased as possible in presenting this information? And it's highly context specific. Again, coming from public health, frequently that there's been a societal decision that smoking is bad for you, and so at a societal level, we are completely comfortable with fear appeals, saying that with the cigarette packs with pictures of people with horrible throat cancers and things like that, especially anyone in New York City, there's all those ads on the subway with people who've had their fingers amputated and all that sort of stuff. So at a societal level, there are certain things that we globally think are fine for persuasion. There's other things where we globally are pretty sure they're not. And it also matters your motive for the persuasion. That's why we think if you're trying to persuade for marketing purposes, because you want to sell more x-rays, that's probably not a good motivation, or more drugs of some sort. But I think it is pretty context specific, because the professional community is always going to have more information and more knowledge about the situation than the public is. And so they're always going to have control over that, how that is communicated.
Well, I'm not so sure I would agree with your analysis, but because, persuading with, the tobacco campaigns, very effective, I think, advertising around what people look, that's not misleading. I mean, it's just straightforward. It's just in your face. But there's a difference between...
Patients don't get those cancers.
I understand that.
Right. So we're not interested in telling them how much their risk improved. We are just saying, okay, take it from us. This is really risky.
But the consciously misused information in a way that we know inflates, the message or the takeaway by, say, using a relative risk sort of presentation as opposed to an absolute risk. That seems to me to be just a little different. But anyway.
The fact that this is an ethical issue is why there's not a factual answer to this discussion. We are scheduled for a 15-minute break. I think we can take the full 15 minutes. So if people could be back by 20 minutes after, by that clock, thank you.